Hello, I'm Grace, a biological and medicinal chemistry student from the University of Exeter, and in this video we shall be discussing the various arguments surrounding the anti-psychiatry movement. Before we begin, let's determine what exactly psychiatry and the anti-psychiatry movement are. Psychiatry is defined as a field that is focused on the diagnosis and treatment of mental illnesses, and the promotion of good mental health. As a medical field, psychiatry can utilize more treatment options than psychotherapists, and thus can prescribe medication in addition to talk therapy. In comparison, anti-psychiatry is a movement which criticized the field of psychiatry, from its diagnoses and treatments to its theoretical basis, as they felt that psychiatry was ultimately harmful to patients. The movement initially occurred between the 1960s and the 1980s, and was led by psychiatrists who were highly critical of their own field. However, as the movement transitioned into the modern day, a wider range of perspectives have been included. Thus, we shall investigate the core arguments that have persisted across the historical and modern forms of this movement. In this video, we should be discussing 4 points: how psychiatric care is effective and beneficial in improving patients' quality of life, the biological basis of mental illness, which fuels the need for a biomedical model of psychiatry, how the specific diagnostic labels of psychiatry can be used to categorize, stigmatize, and further oppress marginalized communities, and the myth of mental illness, in which mental illness is solely a natural response to living in an oppressive post-colonialism society, and the medical system's role in normalizing oppression. To begin, let's discuss a core belief of psychiatry, which is that psychiatric care improves patients' quality of life. Psychiatrists themselves have witnessed the impact psychiatric care can have on reducing patient symptoms and improving their well-being, as psychiatrists can hear directly from patients whether their quality of life is increased. This belief has also been validated by empirical evidence. In a study analysing health records at a Swedish psychiatric hospital, patients who were being treated for conditions ranging from depression and anxiety to schizophrenia and personality disorders consistently scored higher on the Global Assessment of Functioning scale following treatment, indicating a reduction in symptoms and an increase in well-being and ability to function. Further, psychotropic medication, which has been used in psychiatry since the 1950s, has been demonstrated in clinical trials to be effective in reducing symptoms, and is particularly beneficial when used in combination with other therapies. Psychiatry does recognise the issues exist in current mental health care systems, such as a lack of funding, resources, and chronic understaffing, which limit the extent of treatment provided in the UK. However, these failings are not the result of the diagnoses or psychiatric practices themselves, which are effective, but are rather failings shared by the entire healthcare system. The belief that medicalized psychiatry is beneficial and necessary was also supported by the evidence for the biological basis of mental illness, and thus the development of a biomedical model of psychiatric care, which is persisted in various forms from the 1920s to the modern day. Under the biomedical model, mental illness is not the result of social or environmental factors, but rather a physical abnormality that manifests in the brain, and that because it is a biological disease, biological intervention is needed, legitimizing the need for medically based psychiatric care. During the early anti-psychiatry movement, psychiatry cited evidence such as the success of various medical interventions, such as electroconvulsive therapy and psychotherapeutics, along with a chemical imbalance theory, which suggests that mental illnesses occur due to imbalances in neurotransmitters, which could be observed through changes in neurotransmitter levels in response to psychotropic medication, followed by a reduction in symptoms. Although psychiatry later questioned the validity of the chemical imbalance theory as an explanation for mental illness, other biological causes for mental illness continue to be investigated, such as the successful identification of genetic risk factors for conditions like schizophrenia and bipolar disorder, supporting the modern biomedical model. Further, the characteristics we use to distinguish different mental illnesses continue to be improved, which will support our ability to correctly categorize patients for treatment and research, improving our understanding of mental illness. From the perspective of psychiatry, the evidence supporting that mental illnesses are biological diseases justifies the need for medical intervention, and provides patients with the best chance to reduce their symptoms and improve their quality of life. However, anti-psychiatry can question these points in return. If psychiatry is so widely beneficial to patient populations, then why are many diagnostic labels used to oppress marginalized communities? This can be seen in the diagnoses such as oppositional defiant disorder or ODD and conduct disorder or CD, which are characterized by aggressive, defiant, and argumentative behavior and are typically attributed to children. However, diagnoses of ODD can be influenced by unconscious biases that affect how a child's behavior is perceived, such as the view that ethnic minorities are inherently violent. This is further complicated by the lack of specificity in ODD diagnostic criteria, which overlap with conditions like ADHD, anxiety, depression, and PTSD. These biases and lack of diagnostic specificity lead to Black, Hispanic, and low-income children to be diagnosed with CD more frequently, while white, high-income children with similar behavior issues are more likely to be diagnosed with ADHD. Further, following a diagnosis of ODD, children are often labelled as future criminals by psychiatrists and authority figures. This leads to children facing increased stigma and social isolation, disproportionately extreme punishments in response to undesired behaviours, and a self-internalization of the delinquent label, creating a self-fulfilling prophecy that leads to incarceration. ODD is also not the only stigmatizing diagnosis which is disproportionately attributed to minority groups. Borderline personality disorder is used to categorize difficult patients, which targets disabled patients with complex mental health issues. This diagnosis leads to patients and their symptoms to be perceived as manipulative, resulting in a subsequent denial of all medical care to avoid feeding into the patient's manipulative desires. These diagnostic labels can create significant social stigma, support harmful stereotypes, and allow oppressive systems to other and forcibly detain individuals who are considered threats to the system, resulting in the weaponization of psychiatry to perpetuate colonialist systems as the field can be influenced by external political and social beliefs. However, arguments of anti-psychiatry go beyond just questioning whether specific diagnoses cause more harm than benefit, as anti-psychiatry asks if mental illnesses are even illnesses, or simply normal human responses to modern society. The effect of the COVID-19 pandemic on mental health is a particularly recent example of how oppressive environments can contribute to the development of mental illness. In a study conducted in the US and the UK, it was found that ethnic minorities experienced higher rates of depression and anxiety due to the pandemic than white individuals, even after controlling for the effects of social isolation. These disparities in mental illness rates have been attributed to the role of the pandemic in exacerbating systemic inequalities faced by marginalized groups. Under the tenets of anti-psychiatry, the development of these mental illnesses is not due to biological abnormalities, but rather symptoms of anxiety, depression, and psychosis are a natural, albeit harmful, coping mechanism to the trauma of living in an oppressive and unequal society. However, if mental illness is normalized as a biological failing, not only does it place the blame on the individual for their suffering rather than on the systems of oppression and capitalism, but it also obscures the harm that these systems cause, making them more difficult to dismantle. Further, the medicalization and treatment of mental illness benefits capitalism more than it benefits patients, as simply alleviating symptoms so that patients can return to work does not address the underlying oppression that is the cause. Ultimately, however, it is my opinion that psychiatry and its criticisms can coexist with each other, and it is likely essential for the future of the field that these criticisms are incorporated to benefit patients. Although the medicalization of mental illness may be obscuring the effects of oppression as biological abnormalities, simply eliminating psychiatry without first dismantling oppressive systems will lead to mental suffering without any means to reduce it. Likewise, there may be a biological basis of mental illness. However, to ignore the substantial effects of environmental and social factors on mental illness will ultimately reduce our understanding of mental illness and its treatment, and thus a biopsychosocial model should be more widely adopted. Psychiatrists want to promote the health and well-being of their patients. However, they will not be able to successfully do this without first confronting how current psychiatric practices are leaving marginalized patients behind. To conclude, I would like to leave you with these questions to consider. What benefits might diagnoses have for patients? What harm can they cause? Does the current biomedical model of psychiatry support our understanding and treatment of mental illness? If systemic oppression and the effects of colonialism could be addressed, would mental illness continue to exist?